Acute abdominal pain is one of the most common and most dangerous reasons patients show up to the emergency department. Surgeons have to act fast, but with precision. So, how do we think? How do we decide who needs a CT scan, who needs to go to the OR, and who just needs Pepsid or discharge? Today, we're diving into the surgical mindset behind the acute abdomen. Let's start with basics. An acute abdomen is any sudden onset of abdominal pain that may require surgical intervention. It can be life-threatening, thinking of perforated ulcer, ruptured appendix, ischemic bowel, or ruptured ectopic pregnancy. Other things are perforated diverticulitis as well. But not every acute pain means surgery, and distinguishing between surgical versus non-surgical is the art or science of the job. So I'll let you take a look on the surgeon's mindset: pattern, risk, and speed. When a surgeon's called to the ER for abdominal pain, three things are racing through their mind. What is the pattern? What's the risk of missing something dangerous? And how much time do I have before this goes south? This is pattern recognition, which meets damage control. We're balancing uncertainty, time, pressure, and imperfect information. The three big questions every surgeon asks is this surgical? Red flags include peritonitis and free air on X-ray. Number two, is this urgent? Can I get labs and imaging first, or do I need to rush to the OR now? Rushing to the OR now meaning an acute abdomen on somebody who's either bleeding or in shock, and you don't have time to actually go through the CAT scan and evaluate. Number three, worst case scenario that I can't miss: mesenteric ischemia, perforation, ruptured AAA. So you have to balance all of those because those are things, and you have to determine who is going to be which patient at risk for what disease. So let's actually look at some scenarios. 65-year-old male with sudden onset of upper abdominal pain after dinner. History is key. Here's what we listen for: sudden or gradual? Is it localized to the right lower quadrant, which may make us think of appendicitis, versus is it diffuse that we're worried about peritonitis? Does it go to the back when it resembles pancreatitis, or to the shoulder when there's blood in the peritoneum? Is it crampy versus sharp versus colicky? Any associated symptoms? That may include vomiting, fever, GI bleeding, urinary symptoms. Red flags include pain out of proportion in your physical exam. Think about mesenteric ischemia. But it doesn't happen to everybody. You have to think about who is going to be at risk. Those people who are vasculopath, those people who have clotting disorders that are procoagulant, elderly people. Other risk factors include immunocompromised or pregnant. Patients may have atypical presentations. And sudden onset unrelating pain is often serious. What are the physical exam findings which we consider as pearls? Now, to the hands-on work. What are we looking for? Rebound tenderness. This suggests peritoneal irritation. Guarding. Is it voluntary or involuntary? Is the abdomen rigid? Think about perforation or widespread peritonitis. Is there localized tenderness, which points toward an organ? If you listen to bowel sounds, is there going to be an ileus or obstruction if they're not present? And don't forget, don't skip the rectal or pelvic exam because this may actually provide an additional clue. Don't forget the classical examination findings of Murphy's for acute cholecystitis, psoas and obturator signs, which shows a retrocecal appendicitis. These are old school but may still be useful. So when do we image patients? Well, imaging is helpful, but don't delay intervention if they're unstable. When stable, here's the usual approach. Majority of the patients are going to get a CAT scan of the abdomen and pelvis, and majority of them will have IV contrast. If the concern is going to be a mesenteric ischemia, then angiography is considered as a CT angiography. People with biliary disease, or if they're pregnant, ultrasound is going to be a good screening. Plain X-ray is a good starting point when you're looking for free air or obstruction patterns. But most of the time, this is supplemented by CAT scan to be able to delineate the anatomy better. Remember, no single test replaces good clinical judgment. So the next question is, once you've evaluated the patient, the question is operate or observe. This is where the surgeon's judgment shines. If a patient has peritonitis, free air under the diaphragm, and signs of ischemia or necrosis and they're unstable, go to the OR. But what if it's clear? We observe? Well, you can do serial abdominal exams, repeat the labs, and then you could provide fluids and supportive care while maintaining them NPO. But in any patient that you're observing, you have to understand what your goal parameter is, which could include that they're improving, or if they're worsening or not improving, then you may have to consider some form of diagnostic laparoscopy or exploratory laparotomy. So let's wrap up. Let's tie this all together. When facing acute abdomen, surgeons recognize patterns, ask key clinical questions, prioritize risk and time, use imaging and exams wisely, and know when to cut and when not to. If you guys liked the video, please click the like and subscribe button and type in the chat if you have any questions. I'll be happy to answer them. And check out the other videos we have, and I'll see you guys next time.